Welcome, everybody, to Cardiovascular Medicine Grand Rounds. It is my great pleasure today to introduce today's speaker. Dr. Michael Holinstat obtained his Ph.D. in cardiovascular pharmacology at the University of Illinois. He then underwent a postdoctoral research fellowship in translational pharmacology at Vanderbilt University and joined the University of Michigan in 2015. He is currently a professor in the Department of Pharmacology and a fellow of the American Heart Association. Dr. Holinstat's research interest focuses on understanding lipid, lipoxygenase, and oxygenase regulation of platelet signaling and function, and how it relates to regulation of homeostasis and thrombosis. He serves as the inaugural director of the Platelet Physiology and Pharmacology Platelet Core at the University of Michigan. Additionally, he serves on several national boards, including the Subcommittee on Hemostasis and Thrombosis at the American Society of Hematology, and he's the director for the NIH CTSI-funded T32 training grant in clinical research. Dr. Holinstat has received several national awards, including the Kenneth Brinkhouse Young Investigator Prize in Thrombosis from the Council of Atherosclerosis, Thrombosis, and Vascular Biology in 2012, and the Young Investigator Award from the Eicosanoid Research Foundation in 2013. He has received numerous patents from the US, EU, and Japan for various therapeutic discoveries to treat cardiovascular disease. In addition to his NIH funded research, he continues to translate his discoveries into potential clinical applications in partnership and collaboration with industry. Dr. Holinstat has published over 106 peer-reviewed journal publications in the area of platelet biology and lipids, and his work has been highly cited in prestigious journals. Dr. Holinstat has spent the last 20 years training the next generation of clinical and translational scientists in the area of blood clotting, platelet biochemistry, and discovery of novel therapeutic approaches for learning thrombosis. Today, he's going to be talking to us about emerging interventions for the prevention of thrombosis. Welcome, Dr. Holinstat.
Great. Well, thank you for the invitation. It's really a pleasure to be here and talk to you about some of the discoveries and how I am thinking about where we are and where we've come from, where we need to be to adequately and optimally treat our patients. These are my disclosures. Okay, so when I think about cardiovascular medicine, I really take a first line approach of where is the unmet need. And unfortunately, even though we've done a fantastic job of identifying pathology, identifying the target organs, identifying the comorbidities, the mortality risks, the discoveries that have come out have left us with cardiovascular disease being the leading cause of death globally. One person dies every 33 seconds. That's the most recent statistics in the US. And 2022, almost 703,000 people in the US died of cardiovascular disease. By 2035, the number of people with cardiovascular disease is expected to explode. About 45% of the US population is projected to have some form of cardiovascular disease, and that's in the next 10 years. And on the bottom left, you can see from the 2024 studies where those projected numbers are expected to be. Importantly, the projected costs are also expected to balloon. So by 2035, the expected cost to the medical field for cardiovascular disease is expected to balloon to $750 billion from the current $318 billion. So clearly, we are working hard, but we need to do better. So this is an obvious unmet need. I'm going to talk to you and focus my studies on emergent areas in platelet biology and intervention in the platelet, because I view the platelet as the first line therapy for up to 50% of the morbidity, mortality resultant in cardiovascular disease. So what you're looking at here is a pictorial of a vessel, and under normal conditions, we'll have a vascular insult, and quickly you'll have some red blood cell loss, and fibrin and platelets will come in and form a platelet plug. This is hemostasis. Blood stays where it needs to be. Life goes on. People get a bruise every day, but they don't die from it. Unfortunately, more and more people are having a major trauma or injury. In this scenario, this is an atherosclerotic plaque rupture. And in that case, the initial steps are the same. Fibrin is formed, platelets form a plug. However, those platelets continue to be activated in the system to the point where they occlude the vessel. This occlusive thrombotic event results in blockage of the vessel. No red blood cells and nutrients are passing down. No oxygen is getting to the tissues of the body, including the heart, and the patient's organs start to shut down. So this is the major issue we are trying to prevent. So this is the history of what we've done to treat this. It might be surprising to some that we didn't actually have any FDA-approved antiplatelet agents until the 1980s. In the 1980s, Garrett Fitzgerald and others had transitioned and studied prostanoids to understand that we could target COX-1 with aspirin. So in the 1980s, aspirin became an FDA-approved intervention and for the clinic. Quickly after that, we identified that we could target the integrins on the surface, the alpha-2b beta-3 inhibitors. We could target the P2Y12 or purinergic ADP receptor signaling. In 2001, we came up with the great idea that, well, if one hit isn't enough, maybe two hits better. So in 2001, dual antiplatelet therapy was approved in the clinic. So again, that's only 25 years ago. So we are still, in my opinion, in the infancy of where we could be and where we need to be based on the science that existed at the time. We've now come full course through a number of P2Y12 inhibitors, a number of PDE inhibitors, a number of alpha-2b beta-3 inhibitors, and even a thrombin receptor inhibitor, for those of you who remember Vorapaxar and those studies. The challenge is that all the current therapies are targeted to just a few targets, right? So our FDA-approved targets in the platelet are really four: COX-1, P2Y12, alpha-2b beta-3, and phosphodiesterase 3. We all have gone to combination therapy, but as you know, bleeding can be more deleterious than the clot that we're trying to prevent, especially when we get into intracranial hemorrhage. So I return to the unmet need. The unmet need is a critical need, I would say, to develop new therapeutics and a new therapeutic approach, but not by developing new drugs to the same targets that we've targeted since 1980. It's identifying new targets and proteins on the surface or inside the platelet, decreasing platelet activation, ideally by being able to be effective enough to go back to monotherapy if we can find those key targets, but not to the extent that we shut the platelet down, which increases the bleeding risk. Hence the challenge with triple antiplatelet therapy with Vorapaxar, and the challenge with the alpha-2b beta-3 inhibitors. Really great, but they shut down all platelets. They have a very high bleeding risk as a result. So this is what my lab does. My lab has spent our career trying to identify these new targets. I'll talk to you about a couple of them. We'll give you some vignettes, and then we'll recap where I think the field is going and where I think you're going to see new interventions in the clinic in the next decade. So we started with development of antiplatelet inhibitors. I'll talk to you about one we developed called ML355. It was the first in class 12-lipoxygenase inhibitor. I'll tell you a little bit about why we chose that how we developed that, and where it currently sits. We took advantage of the lipoxygenase and lipid field to start to study some of the other oxylipins or oxidized lipids that are produced in the blood and their effects in the platelet. And we used that to identify we discovered a new oxylipin called 12-hetra, which is released from the platelet. I'll go into that a little bit in today's discussion. And we use that to make a new drug. So that's a new drug developed here at Michigan, patented here at Michigan, licensed here, and is looking to actually go into phase 1 clinical trials in the next year. So I'll talk a little bit about how we've been able to fast track the process. We learn over time, do, repeat, learn. All right. So we've learned how to be more effective and efficient in our development process. We don't just develop therapeutics, though. Again, our idea is, what are the emergent targets? And that doesn't always involve us developing the target. Sometimes it's us identifying where those targets need to be developed. So we had done studies previously, genetic studies in healthy humans that were black and white, and identified a polymorphism in a singular receptor on the platelet, the PAR4 thrombin receptor, and had gone on to show in a number of Nature Medicine and Blood and ATBB papers that amino acid is highly expressed, that the alteration in the amino acid in that receptor is highly expressed in the black population, and explains about 70% of the increased risk in thrombosis in that population. And as a result of that, Bristol Myers had developed a PAR4 inhibitor that's now in phase 2 clinical trials. And I'll talk to you a little bit about where we're going. I think that taking advantage of the biology, understanding and learning more about the biology, especially in the area of lipids and the oxylipins that are in the blood and how they're regulating blood coagulation and clotting, is going to tell us a lot about these new targets that we could go after. All right, so why did we choose 12-LOX? So there were a couple reasons. 12-LOX is, arachidonic acid is the most highly expressed fatty acid on the platelet surface. This is a fatty acid that was really investigated back in the 70s and 80s. That's where they came to the conclusion that blocking COX-1 could be a therapeutic, because COX-1 oxidation, arachidonic oxidation by COX-1 results in oxylipins such as thromboxane. And so in limiting the amount of thromboxane that is produced in the platelet limits the platelet activation. But they stop there. And what this slide is meant to show you is there's a whole series of oxylipins just from this one fatty acid that have been relatively untouched and ignored. And so we looked at 12-LOX because we had done the proteomics, the first proteomics of the human platelet. And 12-LOX is in the top 12% of all transcripts expressed in the human platelet. So we then went and looked at other cells and in the blood and realized that, well, if we're thinking about regulation and we're thinking about potential therapy, one of the biggest challenges is off-target effects. Those of you who are treating know that every time you give a medication or a drug to a patient, you have to worry not only about what its intended use is, but what's it going to do to the patient that you didn't intend. And so 12-LOX is unique in that it's only expressed in the blood and the platelet. It's the only cell that expresses it. So you don't have to worry about effects on the endothelium, on the immune cells, on the red blood cells, because none of those cells express 12-LOX. So we went forward and said, okay, if 12-LOX is really important, and I'll tell you from the forefront, I seamlessly will go back and forth between human and animal studies, but I'll try to remember to tell you what study we're doing when in which species. We started with animal studies. We want to know, is 12-LOX important? So we attained 12-LOX knockout animals, and the reality of science is that it's all about timing. When we decided we wanted to get a 12-LOX knockout animal, We called the only person in the country that had them, Simon Karpatkin. He was the division chief for hematology, I believe at NYU at the time. Unfortunately, he had passed away 2 weeks earlier, and the institution had sacked his entire colony. So we spent the next year and a half re-deriving an animal that didn't have 12 locks. So how it goes sometimes. It's okay. We were successful, and what I will show you here is an intravital experiment where we asked a very simple question: is 12 locks important to clotting? So what you're looking at here is a cremaster arterial in a anesthetized animal mouse, and we are going to use a laser to cause a pinpoint inflammatory response to the endothelium and identify whether 12 locks is important to responding to that injury. What you can see on the left is a wild type animal, and what you can see on the right is an animal that doesn't have 12 locks. So you can see on the left, the red is fibrin, green are platelets. We use antibodies to label them. These are real-time in vivo experiments. This is what a clot looks like as it's forming. And you can see on the right, there's an inability to form a stable platelet clot without 12 locks. That gave us a suggestion that, okay, we can move forward. And you might ask, well, why didn't you just start with human platelets and human blood? There were no inhibitors to 12 locks. They didn't exist. So we had to start with the animal to see, is this something worth going after? Once we identified, yes, it is, we teamed up with the NIH and other academic investigators, and we embarked on a drug screen to see if we could identify a highly potent, highly selective, non-toxic drug or small molecule that could inhibit 12 locks, not inhibit any of the other enzymes in the family, COX-1, COX-2, 15 locks, 5 locks, etc. And we screened over 553,000 compounds with the help of the NIH. They would produce the compound, they would send it to us. We would test dozens of them every week in human blood and send back the best hits. And this went back and forth for about 3 to 4 years. Eventually, we identified one molecule of 553,000. One molecule that was potent, worked in human platelets, didn't touch any of the other enzymes, was inhibitory, and was not toxic. Okay, so it's a long venture. For those of you who think that you just go and call up your screening facility at the institution and a month later they send you something, they can send you something, but that's probably not going to be something you're going to put into man and think about treating people. On the right, and I have these slides throughout, it reminds me about, as a translational scientist, what are the competencies we think about in translational science? And some of these are things like efficiency, speed, being focused on what your goal is moving forward. Team science, it takes a team. So I always, in my teams, have physicians, nurses, researchers, phlebotomists, and so on and so forth, knowing what you need to get to that endpoint. Being innovative, being not afraid to break those barriers, and partnerships. So cross-boundary partnerships are really essential. So for example, as was mentioned in the introduction, I not only work with government, but I also work with industry. I'm not naive to the idea that if I really want to get something I discover into man to treat patients and be able to decrease that morbidity, mortality, I'm going to have to work with industry because they have the funds and the resources to drive this forward. All right, so platelet aggregation is one of the assays we use in the lab. It's basically take human platelets. We use with a stir bar. Platelets are non-adherent. So if you have a light source on one side and a detector on the other, the detector won't detect any of the light. As platelets become activated, they clump, they aggregate, they fall out of the light source, and that's seen as an aggregation. So we took our drug that we developed called ML355, and we took human blood and said, okay, can ML355 potently inhibit thrombin-induced platelet aggregation? Thrombin's the most potent activator of platelets, so we wanted to start there. And what you could see is, and we used aspirin as a comparator. So while aspirin does have an effect, we know that aspirin's beneficial, blocks about 30 to 40% of the platelet aggregate. ML355 blocked about 80 to 90% of the platelet aggregation that occurred. Importantly, adding aspirin to ML355 did nothing. So that also gives us a sense that maybe if this is successful, we can replace aspirin. Maybe we don't need aspirin. Maybe we could just target the 12 blocks. We in the bottom you see we increase the concentration of thrombin, which mimics a major trauma. Right? So if you have a major trauma during surgery, you're going to want some clotting to occur. If you shut down the platelets again, you get into that major bleeding risk. And we demonstrate here that when you have a lot of thrombin, aspirin does nothing. But ML355 continues to have about a 20% effect on attenuating the activation. And adding aspirin to the ML355, again, gives no additional benefit. So there's no reason to in our mind, that one would need to have aspirin if you were blocking 12 blocks. We then move to what we call a flow chamber perfusion assay. We take whole human blood over a strip of collagen that mimics an injury in the vessel. Collagen is behind the endothelium. And we run that blood through at an arterial shear rate, similar to what you might see in the coronary artery. And we have labeled the platelets so you can see what platelets adhere. So this gives us a sense of adhesion and adherence on the platelets in drug. And so what you can see on the left, we take blood samples. Half the samples we treat with just a vehicle, and half the samples we treat with our drug. And you can see that the samples on the left, you get very significant adhesion of platelets to that collagen as they're flying across at a millisecond of decision time. And on the right, you get significantly less, but some. And that's important. If we had none, to me as a pharmacologist to say, well, this would cause bleeding. If the platelets can't adhere at all, that means that you can't maintain hemostasis in an injury. We have some. We then worked with a collaborator at Technion Institute in Haifa through the Michigan-Israel Partnership, Natty Koren, and he developed what he likes to call the honeycomb. So as opposed to a straight tube, we now have the blood has to maneuver its way through a system, because at these points of bifurcation, that's where clots often occur. And what you can see again in his honeycomb setup, wild-type platelets form major clots, especially at those points of bifurcation. But in the absence of 12 blocks activity or the presence of a 12 blocks inhibitor, we prevent that. So we then moved, that was all human blood. We then moved to animal, said, okay, well, we want to give this orally. So if we orally dosed an animal twice a day for 2 days, and that didn't do anything for 24 hours, what would happen if there was an injury? And in this scenario, we actually wanted a major injury, a trauma. So we took a mesenteric artery and we added iron chloride, ferric chloride. Chloride denudes the entire endothelium. So you're going to end up with an occlusive blockage of the coronary of the mesenteric artery. So you see on the left are the wild type mice that were just given vehicle, and on the right drug. And you'll see quickly on the left, within 10 minutes, we've obviously sped up, you get a complete blockage. And you'll see this is what the blockage looks as it occurs. So you see the clot form, and very quickly, there you go. There's now no flow to the left of that blockage. So everything to the left of that is now dying because of deprivation of oxygen and nutrients. On the right, what we see is exactly what we saw with the human blood in a flow chamber, which was some adhesion at the edges, but never vertical extravasation across the clot. We then did some really state-of-the-art bleeding assays. This is pharma state-of-the-art. We cut the ends of the tails of a mouse and we count how long it takes for that blood to stop. All right. I know it's surprising people. There's got to be better assays. Unfortunately, actually, there aren't. And what we showed in this paper at ATVB was that whether we used low or high doses of drug, we didn't really cause a bleeding diathesis. We then we're not satisfied with that because humans don't have tails. Tail vein in a mouse may not really tell us a lot about what might happen in man. So we went back to back to the animal premaster arterioles, venules, and we punctured holes in the vessels. We had, in order to quantify blood leakage, we had treated the dextrin into the bloodstream, so we could actually quantify how long it leaks and how long it takes to actually for that puncture to seal. And what we found was that there was no difference in the time for that puncture to seal, whether it was in the arterial or venual, whether they had been treated with or without a 12-LOX inhibitor, suggesting that while you don't get a clot in the vessel, the cessation event where blood is leaking out of the vessel, at that region, you are getting protection. And as a comparator, we gave some animals heparin. Turns out, just like in humans, mice bleed on heparin. All right, so we thought about where could we apply this. So if we now want to go clinically, we want to say, okay, we've demonstrated a new target, we've demonstrated its potential benefit, we know some mechanism of action, but now we want to actually think about how this would be applied in man. We started thinking about a disease that's not well treated, heparin-induced thrombocytopenia and thrombosis. So many of you have treated HIT patients. The standard diagnosis is a 4T diagnosis. When you get the 4T diagnosis, if it's positive and the serum assay is positive, you'll then start treating them with argatroban, a factor 2A inhibitor. The patient will recover. You'll get them off of argatroban and switch them to a DOAC or warfarin for anticoagulant 30 to 90 days. Okay, standard. The only FDA-approved drug for HIT currently is argatroban. On therapy, and I'll just mention that about 12 million patients a year use heparin. 1 to 3% of those patients will develop HIT in unfractionated heparin, and that goes down to 0.2 to 0.3% in low molecular weight heparin. So as many as 300,000 patients a year have suspected HIT, with 30 to 50,000 having bona fide HIT in the US alone. So what happens when we treat with argatroban? Well, when we treat with argatroban, about 20% will still have a major bleed. About 25 to 30% will die. About 10% will have an amputation. And about 20% will have a new thrombotic event. So while this is the only FDA-approved intervention, I don't think I would call that optimal treatment. And so that was, these numbers come from Dr. Adam, they had lead clinical hematologist at University of Pennsylvania who had retrospectively looked at all the studies across the US. So we thought that maybe ML355 could be developed to ultimately treat suspected HIT. In order to get something approved through the FDA and into man, you do have to demonstrate the disease model. And I want to emphasize, it's a model. Mice are not people. Mice are big, complex test tubes that in some ways can assimilate certain attributes we're looking for in a disease, but they are not people. So what you see in a mouse is not necessarily what you're going to see when you dose a person. All right, so we ran into a problem. Mice actually, so the way HIT works, right, is patient gets heparin. Heparin interacts with platelet factor 4, PF4, that's released from the platelet, and then an antibody in some people will interact with that and form a complex. And that complex activates the singular immune receptor on the human platelet, the Fc gamma R2A. Unfortunately, mice don't have an immune receptor on their platelets. So we worked with a collaborator of ours, Steve McKenzie at Thomas Jefferson, who had humanized the mouse platelet for HIT. So he had added the human Fc gamma R2A to the mouse. And with that, we were able to actually conduct and test our drug. So what you see is that when we injected mice with a drug that would induce HIT, if the mice didn't have Fc gamma, nothing happened. They didn't lose any platelets. They didn't get thrombocytopenic. They didn't get thrombosis. If they did have the human receptor within, and that's the black dots, within 30 minutes, they lost about 80% of their platelets. It became severely thrombocytopenic and induced thrombosis. And that's what you see in the bottom left there. That's the thrombi in the lungs after 4 hours. If they were given 7.5 mg per kg of ML355 prior to induction, it protected their platelet count and it protected them from developing thrombi in their lungs. And if the animals were crossed with animals that didn't have 12-LOX, those animals that have the human immune receptor but don't have 12-LOX, they also don't form thrombi and are protected from thrombocytopenia. We recently, last year in Blood, published the first structure paper showing in cryo-EM where ML355 actually binds to the enzyme. Until then, we actually had used predicted identification, which is very common. But now we know that our predictions were correct. It binds in the domain pocket where arachidonic acid would bind. All right, so this development story was to demonstrate that we could start to target platelets in a new way by targeting the enzyme 12-lipoxygenase in the platelet. It started in 2010, but it took us about 4 years to develop ML355. It took us another 4 years to do all the studies necessary to put together a company, license the drug. But we went much faster after that. So 2018, the company was formed, it was licensed. In 2020, we received orphan drug designation. That is the FDA acknowledging that this is a clinically unmet area that needs new interventions. So we received ODD designation for HIT. It was approved by the FDA for human intervention, and phase 1 trials were initiated. 2022, phase 1 trials were completed. The FDA, the data was very promising. The FDA, again, acknowledged the need for a new intervention for HIT, as patients are dying, and there's only one approved treatment currently in the US. So they gave us fast track designation. Fast track designation means you have a team at the FDA to work hand in hand with your studies as you move forward. And so they're currently in phase 2 trials in 20 centers across the US. Hopefully within the next year, they will have completed, they'll be ready to go into phase 3 trials. And with fast track designation, the phase 2/3 can speed up to get these medicines into patients. So if successful, you may see this in the clinic in the next 5 years. Of course, it takes patents to really commercialize something. So we have patents in the US, Asia, Japan, Europe. This drug recently received orphan drug designation in Europe last year as well. So there's a global recognition that this could be a new path forward. So now I want to switch to second vignette. So it's moving forward. It's in the clinic. You may see it. You may see it soon. We took advantage of 12-lipoxygenase. Again, this enzyme that simply adds an oxygen to a fatty acid to make a bioactive lipid, right? Remember back to your med school days. Don't glaze over your eyes yet. Okay. And so there's a lot of fatty acids on the membrane that are not arachidonic acid. We took advantage of a number of these. We looked at DHA, and that makes several oxylipins, and we demonstrated that can regulate platelet function. We looked at EPA. That is a paper that is currently under review now, where so if you were here on Monday, you would have heard Dr. Deepak Bhatt talk about the Reduce It trial. And the reality is we don't have a mechanism of action for its benefit, at least in the blood. And so we're starting to, I have a graduate student in the lab who's really pushing forward in that avenue to understand, why does it work? If it has these benefits, are they due to regulation in the platelet or other cells in the blood? And so EPA makes a oxylipin known as 12-PP, and I can tell you it does have some beneficial actions directly on the platelets themselves. So stay tuned. We had done a clinical trial in postmenopausal women and identified that DPA was important for reducing about 20% of the 2B3A activity on the surface of the platelet in these women that are at high risk for having a thrombotic event. So simply a fish oil or an evening primrose oil application is enough to start to shift their risk away from thrombosis. And so I encourage you, if you want to know more about that, to read that paper. It was a really it was a fun study. We did it here, 90 postmenopausal women, highly reproducible. Every single woman in that study had a beneficial shift in their 2B3A and a limitation of the ability of thrombin to fully activate those platelets. So we think that study was meant to show in a relatively non-invasive manner, could we shift the risk of this very large population that we know has increased risk after menopause? What I'm going to talk to you about in the last 20 minutes, however, is a new drug development program that we have recently developed within the last 3 years, and that is targeting DGLA. I mentioned briefly in the beginning that DGLA makes this thing called 12-HETRA, and we had demonstrated that has some effects. So now I'm going to tell you how. So DGLA, which is dihomogammalinolenic acid, don't say that 5 times fast. DGLA is when the platelet's activated, it gets cleaved from the platelet membrane. It gets oxidized by 12 LOX to form 12-HETRA. And what we showed in human blood was that 12-HETRA, when you that you can measure 12-HETRA in the platelet simply by giving DGLA in the blood. So by adding DGLA, you can see it immediately in the platelets. Platelets take it up. And that you don't really alter the arachidonic acid. So it's not a competition, as Deepak mentioned on Monday. A lot of this is a ratio. You're increasing the ratio of DGLA. You're shifting the regulatory function to that. All right, so we started by looking at several agonists. I show you here collagen. You've seen the aggregation. So if we give 12-HETRA, we can inhibit collagen-mediated platelet aggregation in human blood. We then went to animals and said, okay, well, if we give that DGLA versus AA or LA in wild-type animals, does it affect aggregation? Only the DGLA did. What if they don't have 12 LOX? So is it the DGLA? I mean, maybe it's going through COX-1, or maybe it's going through a P450, or maybe it's just crowding the membrane, right? So if we knock out the 12 LOX enzyme, we lose all protection. We lose that decrease that DGLA was giving, suggesting it's actually the oxylipin and not the DGLA itself that is regulating the function. So we went in vivo in animals, and we IV administered either DGLA or 12-HETRA. And what you can see is in DGLA or 12-HETRA administered animals, you have attenuated the platelet activation that occurs at a point of injury. So DGLA works, but it's working through 12-HETRA, and in the bloodstream, if you have DGLA, you're going to be protected. Through a number of studies in the lab, biochemical assays, we had identified that 12-HETRA works through activation of a GS-coupled GPCR, meaning it makes cyclic AMP in the platelet. As we know, cyclic AMP is protected. That's the whole concept behind the phosphodiesterase 3 inhibitors that are used, is to maintain a cyclic AMP level in the platelet. Well, so we're now, by giving DGLA, you're increasing cyclic AMP, which causes activation of an enzyme called protein kinase A, which inhibits platelet function. However, there are a number of receptors that actually activate cyclic AMP. There are a number of GS-coupled GPCRs. So we use pharmacologically, we wanted to identify, well, which one do we think it is? So we blocked many of the receptors. So blocking EP2 and EP4 had no effect on the ability of 12-HETRA to inhibit platelet activation. Blocking PGD receptor, the DP1 receptor, had no effect. But blocking the IP receptor, the prostacyclin receptor, fully reversed the effect of 12-HETRA. This gave us the first sense that this oxylipin that's now made in high concentrations is regulating platelets through the prostacyclin receptor. We then, Garrett Fitzgerald over at University of Pennsylvania was kind enough to gift us IP receptor knockout animals. So we switched to animal studies, to genetic studies. Previously was human. Then we said, okay, so if an animal doesn't have an IP receptor, does 12-HETRA still have an effect? And what you can see here is, in the absence of the IP receptor, giving 12-HETRA has no inhibitory effect on platelet aggregation. Similarly, if we look downstream at the pKa, one of the things that pKa does is it phosphorylates a protein known as VASP. And so we look at VASP as a readout, and you can see that animals that don't have the IP receptor, if you give 12-HETRA, you get no VASP phosphorylation. However, if we stimulate something downstream of the receptor with force cooling, we activate adenyl cyclase, you maintain activation. So the system's intact, but the receptor's not there. So again, proof positive that it seems that it is this receptor that 12-HETRA was going through. This is really important background because this kind of sets us up for how we want to think about this clinically. So we then worked with the state fund and said, we have 12-HETRA. That's not really a therapy. It's a lipid that exists. We need to make something. So let's make something like 12-HETRA, but not 12-HETRA. And that what we came up with is CS585. You may have heard me talk about it previously as OxyProtect, because that's a much cooler name. But it's been licensed to Cereno Scientific, and so now it gets an alphanumeric called CS585. This is what 12-HETRA looks like. This is what CS585 looks like. To the untrained eye, they don't look anything alike. My industry medicinal chemists tell me these are very similar. So I believe them. Although I will tell you, we believe but don't trust. So we have to test. And so platelets can be activated, as you know, through many signaling pathways. So we looked at CS585 dose-dependent inhibition of platelets through thrombin, collagen, and ADP. It dose-dependently inhibits all three of those pathways at the low nanomolar level. IC50s of about 15 to 25 nanomolar. By 100 nanomolar, all platelet activation is gone. We then looked at the alpha-2b beta-3, the integrin activity. We looked at granule secretion. And what you can see, and this is flow cytometry using antibodies in human. This is all human blood. And what you can see is that we dose-dependently can inhibit alpha-2b beta-3 activity at the nanomolar level of CS585. Similarly, alpha granule secretion, we measure P-selectin on the surface, and we measure dense granule secretion. So all three, both types of granules, as well as the integrin, are dose-dependently inhibited by administering CS585. So what's the dose that we see the actual cyclic AMP formations? We've directly measured that. And you can see significant amount of cyclic AMP by 50 nanomolar of drug. And by the time you get to 100 nanomolar CS585, you have almost as much cyclic AMP as you get by directly activating adenyl cyclase. One question came up is, well, maybe this is just non-specifically regulating this, and maybe it also regulates cyclic GMP. So we looked at cyclic GMP, and what we were not able to identify any change in cyclic GMP levels in the platelet, even as high as 100 nanomolar of drug. So this is a Western blot demonstrating what phospho-VASP looks like, and you can see that even at the red is the phosphorylation component. You can see even at 100 picomolar, you can biochemically see the activation or the beginnings of the activation of the receptor. You can start to see VASP phosphorylation. And by the time you're getting to 1 to 10 nanomolar, there's a lot of phospho-VASP, meaning there's a lot of pKa activity. And this is the dose response curve for that. To confirm that it's really going through that system, we pharmacologically inhibited pKa. And so if we give CS585 and in the presence of protein kinase A inhibitor, we don't get any VASP phosphorylation. So it is absolutely going through this pathway through forming cyclic AMP and activation of pKa. We then looked at the sensitivity and selectivity. So this is the dose response curve I showed you previously. If we pharmacology, this is all human blood, if we pharmacologically inhibit PGD2, has no effect. EP2 and EP4 has no effect. If we pharmacologically inhibit the IP receptor, we block all phosphorylation. We then turn to animals to genetically confirm this. And so what you can see is in wild type animals and IP animals, if you directly just activate adenyl cyclase, you get VASP phosphorylation. However, if we give CS585, even as high as 10 micromolar, you get no phosphorylation in an animal that doesn't have an IP receptor. So pharmacologically in human blood, genetically in mouse, we see the same thing. And then we, of course, went to in vivo studies. This is animal. And what we could demonstrate here is that CS585 prevents clot formation. However, in an IP knockout animal, and I think of IP receptor as the brake in the platelet, take away the brake, the control, the amount of platelets that will activate increase. And importantly, adding CS585 does not decrease that at all if the animal doesn't have an IP receptor. However, if you look at the dark blue and the black, that's wild type, you can see an 80 to 90% prevention of platelet clot forming at a site of injury when CS585 is administered. Does this work in aggregation? Again, I'll really quickly, no effect blocking any of the other GS receptors, but blocking the IP receptor, you completely block any effect on human platelet aggregation. So we then went to measure perfusion chambers. And so at high shear, and at high shear, what you can see is that CS585 on the right significantly decreases the amount of platelets that can adhere to collagen and in whole blood as they're flying by. Now, why does this matter? Because I was going to say, well, you just showed me a whole bunch of other assays. Many of those assays are using washed platelets or platelet-rich plasma. This is whole blood, right? And so that really matters because a lot of drugs will fail at the point of whole blood because they get sucked up by albumin, they bind to red blood cells. It's a sink. So we really wanted to demonstrate that in man, people don't have PRP circulating in their blood. They have blood, that it actually works. So this is these are still shots of dose dependence that we showed. And then we did another experiment where we, in the bottom row, we added an IP receptor antagonist before adding the CS585, completely reversed the inhibition. We wanted to know what the dose dependency was, and you can, so we dosed the animals at different doses. So how low can you go, right? And so we can go as low as 1.5 mg per kg and have significant inhibition of platelet activity, and then only having regulation on the fibrin at very high concentration. I'd say very high, 6 mg per kg, which in this drug we consider high. Now, many drugs you see are given at 100 mg per kg, but we start at 6 as a very high dose, and we go down to 0.5 mg per kg. And you can see that 6 mg per kg, you do have about a 50% decrease in fibrin, and I think that's due to the procoagulant inhibition. You're blocking the PS exposure on the surface of the platelets that forms a 10-ACE complex. It allows thrombin to be formed. And I think when you have lower doses, you're able to affect platelets, but not induce that, regulate that PS shift. We wanted to know how long does it work for? So we gave a single IV administration and demonstrated that for at least 18 hours, one single administration was effective enough to completely block clotting. We then went to oral administration. And here we demonstrate that if you look at the second row, that is 24 hours after a single oral administration of 3 mg per kg. So 24 hours later, full inhibition of injury-induced clot formation. Importantly, and you know this as clinicians, importantly, we don't want irreversible drugs, right? 48 hours later, we get a full reversal of the clot. So what we think is that it's binding tightly, but not irreversibly. And within 48 hours, you can reverse that effect. But up to 24 hours, so we're thinking maybe this is something you could give once a day, once every other day, and have effectiveness. But it's not, it doesn't kill the platelet like aspirin does. So does it affect bleeding? It doesn't. We've used, so we looked at low and high doses of CS585. We've looked at male versus female. We don't see an effect. So, and then finally, we're working with a team in Melbourne, Australia, that are world experts in cryo-EM and GPCRs. And we've now identified the exact domain and amino acids that this drug binds to in the receptor. So we know actually in the pocket now that it binds inside the IP receptor, but that it binds differently than selexipag or iloprost. And so that's a study that we hope to be publishing soon. So in summary, icosanoids represent a novel antiplatelet target. We can now think about targeting 12 locks. Again, hopefully you'll see this in the clinic in the next 5 to 10 years. It's a new tool in your toolbox to think about. We also can regulate platelet activation by regulating the IP receptor. In this case with CS585, but I'll tell you there are a number of oxylipins that do target the IP receptor. So this seems to be a resounding theme in blood biology that has been underappreciated. Just to give you a sense of timing, we started in 2014 working on 12-heter. We identified it in 2014. By 2018, we had initiated drug development. That only took us 2 years, so cut our time in half. I feel pretty good about that. So by 2020, CS585 was developed. It was patented at Michigan. It's been licensed to a company called Cereno Scientific out in Sweden. It's undergoing preclinical development now. Our first paper came out last year in Blood, received a podcast and an editorial on a potential new therapeutic approach. And again, I hope that this might be one, if not, but not the only new tool in your toolbox. And final slide I really want to go over is, well, I've talked a lot about the development we're doing for emergent therapy. I'd be remiss if I didn't tell you about what else is going on, right? So Bristol Myers has a PAR4 inhibitor is a small molecule that is in phase 2 for thrombosis and coronary artery disease. There's a GP1B59 drug that's an antibody that's in phase 2 clinical trials for TTP and non-ST segment elevation MI. GP6, which is traditionally known as the collagen receptor, although there are many of them. GP6 is, there's 2 versions of inhibitors. There's the fusion protein, which is known as Revicept, and that has gone through phase 2 and phase 3 clinical trials, looking at ITP and HIT. And there's glenzosumab, which is an antibody. That's a newer approach, which is in phase 2 trials for cardiovascular disease and has recently been published, I think last year, in assessing its ability as a triple antiplatelet therapy. And then there's 12-LOX and there's IP. IP, of course, CS585 is something that comes out of Michigan, but I'd be remiss if I didn't talk about ralinepag, which is in phase 3 trials. That's a new version of selexipag. Ralinepag, selexipag, and iloprost, the challenges are off-target effects. They don't selectively hit the IP receptor. They hit a number of receptors, which for those who treat pulmonary arterial hypertension, understand when you give iloprost, there are a number of side effects one has to worry about, and that's not due to the IP receptor. And so there's a lot of hope. That's what's in the table. And in the picture on the right, I have a lot of black boxes. Those are new drug targets that I would say have not been validated. They've been published. They have potential. They need a lot of work, and they don't have actual drugs yet. So PPARs, there's a new appreciation that PPARs are not just transcription regulators for dyslipidemia, that they actually have a signaling regulation in the platelet, and targeting some of the isoforms of PPARs may end up being a beneficial target in the toolbox. And then GPR56 is a non-adherent GPCR. So it's a new type of G protein coupled receptor that myself and Dr. Greg Tall published in PNAS a couple years ago, is highly expressed on the platelet and plays a role in its regulation of hemostasis. So with that, these are the people who did the work. So I would be remiss if I didn't tell you that it takes a lot of work from a lot of people and a lot of team and partnering. So that's my lab, collaborators from all over the world, Europe, Australia, US, Michigan, non-industry support, and then industry support. It takes all of this to actually get something into the clinic, into your hands, so that you have better options and more options to treat your patients. And with that, I'd be happy to take questions.
Thank you, Dr. Holinstat. That was a phenomenal talk, and definitely very humbling to see all the effort and years that it takes to get medications to to the patients. Had a quick question on that topic. You also alluded to the unmet needs in the cardiovascular world. Do you think there's a way of making that process shorter, or do you think that's a process that has to be taken in order to get it right?
Yeah, so that's a great question, and it's a philosophical question because a lot of you'll hear a lot of people talk about the need to bypass the preclinical animal studies and go right into man. And what I will say is the preclinical studies, that's the safety, right? That's, in my opinion, in my humble opinion, is required. I don't want to give a drug to a person and hope that they don't have, that something doesn't go wrong. I want to have confidence that in every assay, every way I could assess, it looked safe and it looked effective. So when we think about that, I don't think you can honestly bypass the preclinical aspect. Where we can actually save some time is repurposing. There are lots of drugs that have failed and when a drug goes into clinical trials, it goes in for one specific indication. So maybe it would be good for maybe it failed in cancer, but it's actually a good target for thrombosis and platelets. And so I think in that respect, you've already done the safety testing. You don't have to go back and do preclinical. You do have to go back and test the model of your disease, but that can be a lot quicker.
We have a question over there.
Thank you. That was an amazing presentation. I know a lot of this data already, but it was great to see it all put together. I have a comment and then a question. So my comment is many years ago when I was a resident, when the residents were responsible for running the nomograms in the hospital, I had to look up the argatroban dosing online, and they had the slogan for it up there. And it was, when HIT strikes, argatroban strikes back. So I think you're really going to have to be creative when you come up with a slogan for your new drug, because that one's a pretty good one. And then my question really has to do with the marshaling of resources. So one thing that struck me watching these two parallel stories was how well you were able to move across industry, NIH, different collaborators and resources to get these ideas to fruition. So could you maybe talk about how you envision discovery science progressing in the ideal state and give some advice to young investigators?
Yeah, so the advice I give to my lab is fail early, fail fabulously. Do the most important experiment. Ask the most important question first. Because if you're wrong, know now and go on to something else. Don't spend years doing little bits of experiments because you're afraid of what the big experiment's going to tell you. I mean, that would be my biggest advice to a junior faculty is don't be afraid to fail. When I went into 12 blocks actually had been determined it does nothing. There was a paper that had come out in the 70s that said 12 blocks doesn't do anything. And I staked my entire career going forward as a junior faculty that it did. And I staked it because of the data I had, not because of a belief, not because of what I read in the literature, but because of what I saw with my hands and what I saw. And I use lots of control. If you've ever read my papers, 3/4 of the figures are control. Because to me, that's what gives me confidence in my results, right? So I think as a junior investigator, don't be afraid to fail. And as far as partnering, people want to partner with you. They want to hear your ideas. They want to help you. So don't keep it to yourself. I know there's this old idea like, somebody else knows what I'm doing. They're going to scoop me. People want to help you. They want to see you succeed. I've never said no to anybody who's come to me and said, hey, I have this idea, I have this drug, I have this target. Can you test it? Can you help me? Sure. Because that's what science is about. It's about the common goal of advancing and getting to better treatment of patients. And so just be collegial, be open, and utilize mentors. You have such amazing mentors here. Use it. Use the resource you have.
So first of all, I just have to say publicly, Dr. Holinstat, you are an institutional treasure. So if it's not said, you are, and we all, especially in the CBC, we really appreciate what you do. We appreciate the help that you lead our research network, you're part of it, and just thanks for everything you do. Then I have a scientific question. So there's such an impressive increase in cyclic AMP as a second messenger. Have you had thoughts of testing this in other things? Like, you're very focused on platelet biology because that's what you do, but it looks like this be very powerful vasodilation as well. And I know you and I have worked together on something in that area, but have you thought about other uses, maybe in an area like sepsis, because it might help endothelial integrity? All those things that cyclic AMP does, can you test it in other diseases?
Yeah, no. So I've thought about not just the endothelium, but the immune cell regulation. So I'm collaborating now with Jason Knight on an APS project, antiphospholipid syndrome, because netosis is cyclic AMP dependent as well, and brings in the immune platelet correlate. Hypertension is something I'm really interested in understanding more about how what a focused drug on the platelet might do to the overall endothelial integrity, right? And the smooth muscle behind that. So yeah, no, I think that those are great questions. And sepsis, yeah, sepsis is tough, right? But it would be great if we had something that we could intervene in sepsis. I'm open to those. I have resources in my lab, and I would love to collaborate with investigators who have that vested interest. Absolutely. Just contact me, please.
Have a question here from Dr. Colling. When in this process do compounds become patented? How does this alter the planning of experiments and the time constraints of this discovery?
It doesn't. No, so in my lab, we have what we call biology, right? You discover biology, you discover mechanism, you publish that. I mean, that's the guts of the science. The patenting of a compound is something you do on the side. You develop a compound, you prove its efficacy, you file a patent. But that should never slow down your science. I would never forego my science in order to patent. They should be simultaneous. And so often, with our 12 locks, we filed patent when the first paper was accepted. Like, we had the patent attorney sitting there with a button. So at first disclosure, right? And so, yeah, you want to wait they want you to wait as long as possible. I work with Innovation Partnership. I suggest any of you who think you have something that is patentable or you want to go down that direction, sit down and talk with them. They have experts. So I have what are called mentors in residence. These are people who've done this over and over and over again, who give me advice. When I have a question, I call them up and say, I have this thing. I think it's important. I think it might be something we could translate and commercialize and put into a man. What do you think? And how would you go forward with this? And so I would say, again, we have some really powerful resources here. When I give talks at other institutions, I often will hear, we're not Michigan. We don't have those resources. We don't have that really strong tech transfer. We don't have people who've done it, been there, done that to bounce off the ideas. You do here. I would take advantage of it.
All right. Thank you so much. This was a great talk.